So we're most thankful to Per Andren for presenting the webinar today. He is a clinical psychologist and a PhD student from Stockholm, Sweden, from where he joins us this morning. His thesis is on behavior therapy for Tourette's, specifically for internet-delivered treatment and primarily ERP. And he is also one of many authors of the recently updated European Clinical Treatment Guidelines for Tourette's. I hand it over to you, Per.
Thank you, Julian, for that presentation. All right, so we have around 50 minutes of presentation. We will focus on exposure and response prevention for Tourette syndrome. And then we will have around 10 minutes of questions. So please send the questions in the chat. You can do that all through, and then we will look through them towards the end of the presentation. And I will try to keep an eye on the clock here and see so the time management is all right. But if there's something that won't be fit today, I think we have a little bit more of extra space in the next presentation in a month. So I would just move it to there. So the slides will be available. You will get them from Julian if you not already have. All right, so what we will go through now is in part one now today, we will talk a little bit about the diagnostic criteria and characteristics of Tourette syndrome and tic disorders. I guess many of you are already aware of this, but I thought it's a little bit weird to start talking about treatment without giving the background. So I think we need to talk a little bit of 10 minutes or so about that. So we build a little bit of a foundation for you, so we can add on the treatment guidelines, which is the next part, and then we're going to narrow down and focus on the exposure and response prevention, ERP, which we will be talking about today and also in a month's time. So I've divided it into two parts. So part one is today, obviously, and then we will be the question session. And from what I understand, some of you might be orientated in the behavior therapy for Tourette's already, but in the habit reversal training, or what it's also called in North America, the comprehensive behavioral intervention for tics, the CBIT. So I will talk a little bit about that as well, because we need to compare this ERP to the CBIT, which you may know more about, because I guess a usual question is, when should you use what, and how do they actually difference that? So we will talk a little bit about that as well. But starting now with a little bit of a background, the diagnostic criteria. If we look at the DSM-5, which I'm sure many of you are aware of, the definition of a tic is a sudden, rapid, recurrent, non-rhythmic motor movement or vocalization. Onset should be before 18 years of age, and it needs to have persisted more than 1 year before tic onset to be able to fulfill the diagnostic criteria for these two, the second and the third diagnosis here. But for the first diagnosis, it's fine. It's if you've had it less than 1 year, then it's called provisional tic disorder. And then if you've had tics for more than 1 year, then it kind of moves over to the category of persistent chronic motor vocal tic disorder. That is if you've had motor tics only or vocal tics only, and you've had it for more than 1 year, then it's called that. And then if it's been more than 1 year since onset, and you've had more than one motor tic, multiple motor tics, and you've had at least one vocal tics, that's when it's called Tourette's disorder or Tourette syndrome. And this is kind of like digging a hole in a way. I mean, if you once have the persistent motor vocal tic disorder, then you kind of have it for life in a way if you just follow the criteria, because there's no way really to get rid of the diagnosis once you've received it if you just strictly look at the criteria, because there's no criteria about you need to be impaired from the tics, or there's no time restriction to it. It's more like a description of a lifetime thing here. And if you've once fulfilled the criteria for Tourette syndrome, Tourette's disorder, then you can never fulfill the criteria for this persistent chronic motor vocal tic disorder again. Then you're kind of you have fallen down into the Tourette's pathway in a way. but this is perhaps an academic discussion. So this is a little bit of a background of the diagnostic criteria, and the full diagnostic criteria can of course be found in the DSM-5. So a little bit about the characteristics. We're talking about motor tics and vocal tics. Motor tics are eye movements. Here's some examples: some eye movements, twitching the nose, facial grimacing, head jerking, jumping, or touching objects. And typical vocal tics might be coughing or throat clearing, or also not purely like vocal tics, but rather perhaps phonic tics would be a better word, because we also have sounds that are made with the nose, like sniffing, something like that. And then other more vocal sounds like grunting, echolalia, repeating what you self say, or coprolalia, like saying bad words, etc. And then there's also this definition of kind of like a spectrum between simple and complex tics, where and it's not really in the diagnostic criteria, but it's often used by clinicians and researchers. And a simple tic is described as more like a brief tic, a very sudden brief tic, involves a limited number of muscle groups, where a complex tic could have more like a prolonged duration, more coordinated patterns, involve several muscle groups, and could also be like a dimensionality of being bizarre and unusual, and etc. And premonitory urges is something we need to talk about. Could also be called tic alerts or tic signals. This is an important thing to be aware of, especially when we're going to talk about behavioral treatment and how to be able to notice when tics are happening or not. And premonitory urges are sensations preceding tics, which are often described by patients, not by all patients, but by most patients. And it seems like this awareness seems to increase with age. So if the youngest patients might not be aware that they feel something before the tics happen, but as older as you get, this becomes more easy for them. And these sensations are usually bothersome. So it's kind of like a negative feeling, and it's an urge to perform the tic. And here are some examples of how this the premonitory urges might be experienced. So as this is some children that has said these sentences here, and it could be like it's a tension or a pressure inside, energy inside the body that needs to come out. It feels like an itch, or like someone is about to sneeze, or like small insects crawling inside of the skin, or like a volcano that's about to erupt. So obviously it's an inner sensation that might not be very easy to put into words, and various patients might have various explanations or descriptions of it. But I think if you look at the whole slide here, you get a feeling of what this phenomenon might be about. So a negative feeling that's preceding the tics. Looking at prevalence, this is if you look at different studies, you end up with various different numbers. But it's a very typical figure is that Tourette syndrome, Tourette disorder is approximately 1% of the population, while the persistent chronic motor vocal tic disorder might vary a little bit. Some say it's more common and some say it's less common. If you look at some more modern studies, people also argue this is the same, more or less the same disorder. It's just a spectrum where perhaps the persistent chronic motor vocal tic disorder is a less severe version of the Tourette's, which is more on perhaps the right-hand, more severe side of the spectrum. And the provisional tic disorder might be then on the furthest left of the spectrum, the less severe one. And for some patients, it also never really develop any of the other diagnoses, obviously, because you see the estimated prevalence for provisional tic disorder in some studies is quite high. So it's fairly typical to have, fairly common to have tics in a certain age, but only a few of these are actually bothered by them, or actually fulfill any diagnostic criteria, or actually seek help, etc. Looking a little bit of the development and course, which I think is very important to know a little bit about, because this if you know this by heart, you will be better at diagnosing this as well, because it will increase your differential diagnostics in a way, because you will know what is untypical and not. And the typical onset is between ages 4 and 6 years, so like preschool age. And the peak of tic severity is described as somewhere around ages 10 and 12 years. And also, which is also described actually in the diagnostic criteria, is that tics usually wax and wane in presentation and severity over time. So that's something typically that parents to patients describe with young patients when there's been an onset. They usually describe that it comes and goes and it's not the same tic all the time, and etc. So there's a variation in symptom presentation, and it's without a doubt more common in boys, 3-to-1 or 4-to-1 ratio. And it looks like, if you look at a group level, that tic severity usually decreases during late adolescence. So it doesn't mean that there's no adult patients, or that adults might not be bothered by this in any way. But if you look at a group level, it definitely decreases in tic severity, and the amount of patients seeking help are definitely less in the adult age than in this peak age around 10 to 12 years. Looking at some risk and prognostic factors, I think also it's worth knowing that some environmental factors can actually affect tics, because that's kind of the basis of working with Tourette's tics with behavior therapy, is that there's some environmental factors that can actually change the tic expression. And naturally, it seems like tic might increase by, for many at least, by anxiety, being excited, so also positive feelings, being exhausted or being stressed. And for many, it might decrease instead during calm and very focused activities, when you're doing what you like the most, or very focused at doing. And there seems to be a very big genetic factor here. I've seen figures of heritability of around 70-80%, something like that, estimates from register-based studies. And but also it looks like also at my university research group, there's been a lot of studies with register-based studies where they've looked at the whole Swedish population, trying to find the various of correlations and stuff. And it looks like there's correlations indicating that there's some environmental factors that might play a role in the development and the etiology of Tourette's, and that might some associations with older paternal age, lower birth weight, maternal smoking during pregnancy, and obstetrical complications. And then before we move over to more the treatment, we also need to understand how is this disabling or impairing for the patient group. And I listed a few points here. I mean, obviously, it's associated with psychological distress. There could be physical pain or injury following the tics themselves. It could be attention difficulties due to the tics, also sleep difficulties. And then, of course, perhaps what many think about is kind of the social isolation part, with being unusual in front of peers and interpersonal conflicts and peer victimization. And in some cases also social avoidance, perhaps not as much as in some other disorders. With avoidance, it's not as typical to avoid stuff in Tourette's as it is perhaps in an anxiety disorder or obsessive compulsive disorder. But there might be social avoidance as a consequence of the tics. And then also in these kind of register-based studies, there have been associations with limited academic prosperity, and also associations with higher suicide risk. So that's worth mentioning as well. And of course, what I did not mention is that it's very common to have comorbid disorders when you have Tourette's, especially ADHD and obsessive compulsive disorders. We're looking at figures of around 50% for ADHD and perhaps 20-30% in some studies for OCD. So it's not, they're not just burdened by the tics themselves, but also by various of other comorbid disorders which also may be important to treat and focus treatment resources. Now moving on to treatment. So there are various guidelines published. This is by Tamara here and colleagues, and this is done by the American Academy of Neurology. This was published in 2019, so fairly recent. So from North America, and then this European version, which I was involved with, which was published just this summer. So I would say these two guidelines are the most recent to date, but they more or less say the same thing. There's some details different there's some differences in the details, but more or less it's the same content. And what they say, if we just try to narrow it down, is that psychoeducation is recommended as a first intervention for all patients, regardless of symptom severity. And when this psychoeducation, like just learning about what tics is and how, and like more or less what I just told you the first 10 minutes, if that is not enough, then behavior therapy, BT, is recommended. And the basis for this, why this is recommended, not medication, is that it's thought to be associated with fewer side effects than medication. There's actually no head-to-head trials actually showing this. Like there's been like a randomized controlled trial where they measure this in any way, but I mean it's fairly accepted that this is the case. But it's also important to mention that medication is also an evidence-based treatment option, and might be very helpful for many patients, and also suitable for many patients. And it's not that super clear cut that everyone should get behavior therapy, and then if that doesn't work, you get pharmacotherapy. So there's many factors that contribute to the treatment decision, such as age, symptom severity, comorbidities, tolerance of side effects, and of course patient preferences, and of course availability. Julian mentioned in the beginning that my research project, the main project in my thesis, is about internet-delivered treatment, how to make behavior therapy more available, because it's not so accessible to many patients at the moment. Moving on then to behavior therapy. And behavior therapy is based on the assumption that tics have neurobiological origin, but that their expression is influenced by environmental factors, as I kind of mentioned previously. So the goal here is to change this symptom expression by using different behavioral strategies. And out of these such behavioral strategies, which we now refer to behavior therapy, there are most evidence for two modalities called the habit reversal training, HRT, and the exposure and response prevention, ERP. And today we will focus mainly then on the ERP. And this is how the evidence looks like. I'm not sure how familiar you are with effect sizes and such, but I will walk you through it. The evidence for BT is mainly based on two large American randomized controlled trials around 10 years of age. They were published around 2011, 2012. And they were on habit reversal training, and it's this package referred to comprehensive behavioral intervention for tics. So it's kind of a package that includes habit reversal training and relaxation training and some other stuff, functional analysis and intervention. And in these studies, they compare this with psychoeducational treatment, was like an active control condition, and they found medium-sized effects of around 0.57 to 0.68, which if you compare that to medication, it's pretty similar as what was the effects you find for various like aripiprazole or risperidone or such when compared to placebo. So perhaps slightly smaller effects for BT, but then you also need to keep in mind that it's an active control condition, which might be more potent than placebo itself in the comparison. So it's kind of like comparing apples and pears. If they're not in the same study, it's really hard to say the effects. But as you see, at least, it looks like behavior therapy is effective, at least to some extent. And looking at ERP, there's only one RCT that has been published, where ERP was compared to HRT in a sample of both children and adults, and both groups improved. To me, this is not like a proper randomized controlled trial, because it was not powered. They did not have a large enough sample size to conclude if these two treatments were actually non-inferior or if one was superior to the other. So it was too small, this study. But nonetheless, this has influenced the field a lot, especially in Europe. And there are two large RTTs of internet-delivered ERP that are currently ongoing, and one of them are actually now published. I don't know if you heard Tamara and I discussed this in the beginning of this presentation before we started, but that study from the UK, called the Orbit study, is now out in Lancet Psychiatry. So if you want, you can look it up there, and you can see that they found an effect that the internet-delivered ERP treatment was superior to the active control psychoeducative control condition. And we're also doing a similar study here in Sweden, which is not yet published. So there's some ERP evidence coming up. Also some open studies also from our Swedish group here, where we looked at ERP and HRT delivered in a naturalistic clinic, like any of the clinics you are representing. How does it work to actually work to deliver such treatment in like real life setting? And you can look that up if you wish. It's got my name, and it's called effect. If you search for effectiveness and Tourette and Andrén, you will find it. It's open access. So if you want to read how we did it in our clinic and how we delivered ERP and HRT in a real life clinic, naturalistic clinic, please look that paper up, and you will get some more information. So the question you might be asking is, of course, what shall we choose, or which one is best, HRT, CBIT, or ERP? And if you look at the American treatment guidelines, they mainly recommend HRT, CBIT, which I think is fair, because to be honest, the evidence for ERP is, as I said, it's face value that it works. There's some open data supporting that it works, but there's not really enough controlled evidence yet for it working. And the European guidelines recommend both HRT and CBIT and ERP. It's not that the Europeans have used any other studies. It's based on the same studies, but there's different interpretations of how much what this actually means for clinical recommendations. Nonetheless, there are several similarities between HRT and ERP, and mainly that both treatments instruct patients to suppress or resist or stop their tics. So in addition, the patients are also instructed to focus on their premonitory urges while suppressing the tics. This goes for both HRT and ERP. Try to suppress your tics and focus on the premonitory urges while doing it. But the strategy for how the patient should suppress their tics partially differs. So in HRT and CBIT, you practice on suppressing one tic at a time using a competing response. So like a movement with your body, like if you have an arm going like this, you might cross your arms like this to prevent the arm tic from occurring. And in ERP, you do not use any competing response. Instead, you suppress all tics at the same time with just more or less your mental power. If you want to read more on the treatments I've been talking about now, I recommend these two manuals. They are published by the same research groups that have conducted these studies, which I mentioned. So this is by the American group, and on CBIT and HRT, and this one is by the Dutch group that did this study on ERP and HRT. They're probably available on Amazon or something like that. You will probably find them easily. All right, now let's check the clock. All right, I think we're all right. So now moving on then to the exposure and response prevention ERP. And this consists then of obviously of two main components: response prevention and exposure. And many of you might recognize this name from OCD treatment. And in my view, I mean, obviously it's the same, but in my view, it's not really the same as, you can't really say, I do this in OCD, so now I know what to do. I'm not saying that this is a complicated treatment, because it's really not. It's very straightforward, but it's not the same, because in OCD you work with anxiety, and what you want to provoke is the obsessions, and then what the response prevention is to not do the compulsions. And also OCD is more like voluntarily controlled. You can actually it's easier not to perform the compulsion. It's not like a neurological movement that just happens. It's something you can control. It might be you might have a lot of anxiety while doing it, and you might not be able to do it because of the anxiety level, but if you really have to, you will be able to do it. But the rationale is fairly similar, but we're talking about, instead of obsessions now and anxiety, we're talking about the premonitory urge. So the premonitory urge, the negative feeling that the patient feels, and then there's kind of like this vicious cycle. So when the patient feels a premonitory urge, they want to let the tic out so that the unpleasant feeling of the premonitory urge disappears, and then they're kind of stuck in this vicious cycle. So now we're moving over to the rationale for treatment, how to explain the treatment for the patient group. So I'm not saying that this is actually how it works, like that this is like the mechanism or something like that, but this is a good way to explain it to the patient, like that they're kind of trapped by the premonitory urges, and what we want to do is try to refrain from letting the tic out, trying to suppress the tics, and trying to more like just let the premonitory urge be and see what happens with it. It might disappear, it might weaken, or it might still be there, but at least they will get better control over their tics. And when you explain this to a young person, the person might say, wow, I've never thought about this, that I could suppress my tics. I thought it wasn't possible. And then they're very happy and they start practicing right away. If you say this to an adult, they might say, well, I've been suppressing my tics for all my life. This is nothing new, really. And then, I mean, what you counter with is that you say that, well, yeah, but I understand that, and you probably already do this partially, but now we're going to try to practice suppressing tics in a more structured manner, and practice for longer times than you've done before, and this will improve your skill in suppressing tics. So most patients can already suppress the tics for at least a short period of time. That's good to know, and also to explain to the patients. And it is not fully certain whether the patients habituate to the unpleasant premonitory urges when performing ERP. If you work with OCD or anxiety, you might recognize these anxiety curves, like the more you practice, the less anxiety you get for each round. You could present it that way to the patients, and it would be a good way for them to understand what this is and how to get started and why this might be a good idea. But I think it's also important to mention that habituation will not occur as linear for everyone. So some will become better at suppressing tics while still experiencing the premonitory urges. There's been a couple of studies trying to show that patients actually habituate to the premonitory urge, but it doesn't really seem like that is the way to go. But still, this is kind of how it's presented in the manual you can buy. So it's probably somewhere in between. For me, it doesn't really matter what the mechanism is. I don't think we will ever know what the exact mechanism is. If it's a rationale that the patient understands and will not become disappointed of because it's too untrue, then I think it might work. If it gets the patients to do the behavior we want them to practice, then I think it's close enough. For children, there's another way of putting it. You could say, tell them to use their brain brakes to stop their tics, kind of like an analogy. And that the brain brakes are located here in the forward part or the front part of the brain, and that they need to use them a lot to break these signals. And the more ERP practice they do, then this makes the brain brakes stronger. And then you can also draw perhaps a parallel to physical workout, like lifting weights or something like that. The more you practice, the stronger you get. And the goal of ERP is to learn to suppress the tics for longer and longer periods of time, and when the premonitory urges are at their strongest and in various situations. So we'll get back to this, but we want to be able to do it longer than before, and when it's really difficult and in all various situations that the patient is encountering. And there's no specific instructions other than trying to suppress the tics. Now we start talking about the response prevention, by the way. Now we're going to suppress the tics. So there's no specific instruction. So this is more like a mental thing rather than with a competing response as you do in HRT. And sometimes families ask me like, but how are we supposed to do it? Where are the instructions? And there's not any instructions like that. It's just start the clock and see if how long you will be able to suppress the tics. So the patient should suppress all the tics at once. It's a good idea to use a stopwatch. Everyone has it in their phones nowadays. You can write down high score times if you wish, especially for younger children. It could be more like, the competition and you're trying to beat your high scores like in a video game or something like that. And what the manual instructs, the Dutch manual instructs, is that you're supposed to continue until the patient is able to suppress the tics during around 15 minutes or so. So when they're supposed to have suppress the tics and there's no tics for 50 minutes during practice, then you're able to move on to the next step, which is the exposure, where we're supposed to try to make the practice more difficult. And moving on then to the exposure, here we want to make the practice more difficult, more challenging by suppressing tics when premonitory urges are intensified and or by suppressing the tics in various situations. So there's like two dimensions here, both trying to provoke the premonitory urge itself and then also try to do this practice while doing various different stuff in various situations. So you generalize these findings. So you're not only able to suppress tics while sitting in front of the clock or sitting at the kitchen table with your parents, but also while you're in school and doing various activities and such, where the patient probably actually wants to suppress their tics most. Many patients perhaps don't care too much if they have a lot of tics at home when they're in their own room or such. Might be irritating, but many, especially adolescents and older, they really focus on the social aspects, and that might be driving for when they want to suppress their tics and not. So the exposure is about provoking the premonitory urges. So there's an exposure to premonitory urges, and then practice to suppress the tics, and that is then the response prevention. And suppress the tics in various environment situations. I think we said all that already. So let's move on. So a little bit an example of how you can expose to the premonitory urges. So this could be that the patient himself focuses on the premonitory urges and when they're sensed in the body. It could also be that someone else helps here, that someone asks the patients about the premonitory urges and tics, or tries to provoke the patient's premonitory urges and tics, or if the patient allows that the parent or relative or whatever can imitate the patient's tics, that might increase the sense of premonitory urges or the tics itself. Could also be looking into a mirror and focusing on the premonitory urges. And I think here, just ask the patient. I think most patients, they know what to do, how to make it more difficult, and when they feel this tickle the most. So just ask a patient, and you would probably be guided about how to make this practice more difficult. And then there's also exposure to situations. There's obviously no rules here. There's a lot of stuff you can do. Here's a list you can use as a reference. Watch TV, play video games, listen to music, do something exciting because that might increase the tics. Cook, bake, use public transportation, be in school or at work, do homework, or rather chores at home. Eat in the cafeteria, do sports, go to a friend, go to the cinema or swimming pool. It could be whatever, really. And then I try to list also some ways to make it extra difficult here. And it could potentially be to do half of the tic, like start doing the tic, and then on purpose stop halfway. Which you can imagine will be very difficult to then because then the premonitory urge is probably very strong and intensive, and then you stop halfway, and then it will be extra difficult to suppress this specific tic. You can also try to change activity during ERP practice, vary between being active and passive, kind of like a circle training thing, or do cognitively challenging activities at the same time, like reading backwards or doing maths at the same time as you suppress tics. For generalization purposes, obviously, to be extra good in demanding situations in real life. Or do activities that creates excitements, like playing specific card games where it's important to have a quick reactivity, or something like that. I mean, there's no rules to this. It's only your and the patient's imagination that sets the boundaries. If you wish, you could also, as an aid for the patient, use an exposure hierarchy, like a ladder. I mean, you probably recognize this for working with anxiety or OCD or whatever. I wouldn't say that it's as important in this treatment as it is in perhaps working with anxiety, but it could be a help. It's like a visual aid for the patient, especially the younger patients, to remember what to practice with and on, and also for the therapist, him herself, to know what did we actually say, decide on, what did we say the last session, and what will we continue on. So I'm always a fan of like workbook materials, visual aids, both for the patient and for the therapist. Will also decrease the chance of drifting away from the protocol and trying to stay focused on what is the most important thing in the treatment. All right. Around 10 more minutes until questions, and let's talk a little bit about the treatment overview. The manuals themselves, they recommend 8 to 10 sessions, or they instruct 8 to 10 sessions. I mean, this is no rule. I always say use as many sessions as the individual patient needs. Some only need 3 or 4, some needs 15. Who knows? It's always individual. There's always, of course, an origin for the manuals recommending 8 to 10 sessions. That is because that was the treatment length they had in the original randomized controlled trials when they evaluated the treatment. So they developed the protocol, they evaluated it in the study. But when it comes to a naturalistic environment, just use as many sessions as the patient needs. And in the beginning, I suggest doing it every week, 1 session every week, and later you can potentially spread it out a little bit more. There should, of course, be homework assignments, and the most obvious homework assignment is that the patients need to practice the ERP, the suppression of tics, at home regularly. And more details on that will follow. I will also give more details on all this in part 2 in a month. And also important to know, I mean, this is a patient group where, you know, the tics, as I said, they naturally wax and wane. They're also kind of prone to relapsing in a way, which kind of goes into wax and waning. So follow-ups are good, and give booster sessions if needed. And that's also what they've done, for instance, in this American manual, this HRT manual. They provided a couple of booster sessions during like a follow-up half a year or a year or whatever it was. So if you have the possibility, do not just let the patient go, and so if they can remain active at the clinic, but with less appointments, and then you can follow them up slowly for perhaps a year or half a year or something like that, then you will be more sure that the patient was actually helped by your treatment, and it was not just like a natural fluctuation that occurred in symptoms that occurred at the same time as you happen to give your treatment, because that happens sometimes. Because, you know, tics naturally wax and wane, and when they search help, they're probably at their worst, because that's when they need help. So then you have like a natural decrease in time, which might occur around 3 months later or so, and that might occur at the same time as you give your treatment. So it's very hard with this patient group to know for sure was it my treatment that helped, or was it just random fluctuation of symptoms, or was it just a combination of various, like what did actually help? Was it ERP, or was it like that we gave a little bit of extra attention to how the parents cope with this at home, and they did not comment on the tics, etc. It's very hard to know, and in my view, much easier to know in a treatment for instance, OCD, if it was like the practice you did that actually helped the patient. But nonetheless, it doesn't perhaps matter what actually helped, as long as you follow the patient up and you can see that the decrease in symptoms is consistent. During the sessions, we're going to talk more about this in part 2 as well, but I just want to say this already now. I mean, obviously you start with some homework follow-up, but then most of the sessions should be devoted to in-session ERP practice. And then, I mean, it should not be, and this goes for like an anxiety treatment, OCD treatment as well. You should not just talk about other stuff or follow. It should be very quickly focused on the practice itself, because then you have perhaps a 30-40 minutes of effective treatment practice, ERP practice each week at least, and that would be very helpful for the patient. And that is also what they did in the studies, the clinical trial that this manual is based on. So that is how they did it, and that is what they recommend. And then of course assign new homework assignments. There's also parents involved, if the patients are children, obviously, or adolescents, and there could be like relatives, partners involved if there's an adult patient, and they also have a role in treatment, especially, I mean, if the patient wants to, and especially for parents then, and that is of course to provide social support, and which is described as encouraging the work with the treatment, reminding about practicing ERP, and also participating in ERP exercises. As you saw, that they could help provoke the premonitory urges and such, and also participate in exercises based on functional analysis, which are referred to as functional interventions. And I will talk more about these functional interventions in the next presentation, which is in a few weeks. And then I also wanted to mention a few myths about behavior therapy for tics, and these were detailed, were described in detail in many publications around 10 years ago, when these large face-to-face randomized controlled trials of habit reversal training and the HRTICBIT program was published. These researchers, American researchers, they had a feeling, or they encountered that patients were a little bit reluctant to trying behavior therapy. They had various thoughts about what would happen if they tried behavior therapy, etc. So they tried to go through these myths one by one and gather data on whether this was actually true or not. And it turned out like the ones that I've listed here, at least, were not true when looked at them more closely in a research study. So one first comment here: if you suppress tics from coming, it leads to more and stronger tics later on. That seems not to be true, because I mean, you could see that rather the tics decreases somewhat after being engaged in behavior therapy. That's what all the evidence is based on. So that's not true. If you treat a tic, then it will move to another place of the body, kind of like if you go to a amusement park and play whack-a-mole, you know, hitting all these moles. It doesn't seem like it works like that either. It just seems like tics just decrease overall when you participate in behavior therapy. Suppressing some tics makes other tics worse. I mean, it could happen because tics fluctuate naturally, they wax and wane. So it could be that if you work with one tic, another tic appears, but there's no clear link that this was because of the treatment itself. Rather, it would probably have happened anyway. Competing responses become new tics if you work with habit reversal training. Doesn't really seem like it's like that either. Focusing on tics in treatment make tics worse. This is probably true in the short term for some people, that when you start treatment, you start talking more about the tics, and there might be some attention in the family about the tics, and potentially some negative attention from the parents before they have really fully understood that they should give just the right positive attention when they practice with the ERP, for instance, and not give so much attention elsewhere. So this might actually happen but what we tell patients then is like, this is for most patients a temporary thing. You're very focused at this now. You think more. You might notice the tics more than you did before treatment, also because you have assignments about the tics. You think about the tics more than you did before. So you might think that they have increased, and they might perhaps have increased, but it's for most patients this is just temporary. And behavior therapy only works for mild tics. Not really. The largest effects are probably for the ones with the most severe tics. They get the largest drops in studies. And BT makes other problems worse. Doesn't seem to be that other not like that either. Anyway, that's the myths. So we know a little bit about that, and this applies, of course, for HRT and ERP. It's for behavior therapy in general. So a little summary of today. Tics, fairly common, and often impairing. Not for all patients, but for many. And tics are usually preceded by unpleasant premonitory urges. Psychoeducation should be provided to every patient that is diagnosed. That's kind of like the level 1 of all interventions. And there are several evidence-based treatment options as the next level, and that such as HRT, ERP, and of course medication as well. And ERP, which we talked about today, is exposure to the premonitory urges and response prevention. And response prevention here is another word for just suppressing the tics. All right. I think time management was okay. So now we have around 12 minutes for questions, if anyone has any questions.
Wonderful. Thank you, Pat. While we're waiting for the questions to come in, I will just launch the post-webinar poll evaluation, so it gives everyone time to fill it out. If I can find it. Might I also add, per one of your points about the UK orbit study, we do actually have that study on our website, the Tourette OCD Alberta network website. If you go to our homepage, there's a new little block there, which is current TS and OCD news, and you'll find that orbit study there.
Very good that you're spreading the news.
Absolutely.
and also the other study I talked about, the naturalistic study, I can paste it here in the chat.
Okay, great. Wonderful.
Maybe I could ask a question. Oh, sorry, someone's put a question in the chat.
You almost saved me there tomorrow, but now there's questions coming in. Would it be recommended to stick with only HRT or ERP? Is there any rationale for combining or trying both with the patient? I actually saved this for the next presentation. I had to have something saved for next round as well, but we can discuss it then as well. I mean, obviously, there's very little evidence to combining these two treatments. So when you look at most research studies, and then I say most because there's one exception here, then most studies are actually on one or the other, but not any combined approaches, which for me, as a clinician, is a bit unusual, I would say, because for me, for instance, if we start with a basis with ERP, I think it would be, as in any treatment you do for an anxiety disorder or an obsessive compulsive disorder, as a clinician, when you sit in front of the patient, you always adjust the treatment so that your patient in front of you can adhere as much as possible. You might use visual aids. You might write on the board. You might explain it in a way that fits this patient or whatever. And then adding, if a certain patient has difficulty suppressing tics with just mental power as in ERP, and there's a certain tic which is a large body movement, I don't see any reason why you would not try to use a competing response in combination to this. It just makes perfectly sense. I don't see how that would go against any of the rationale, because both are about suppressing tics. Both, so if this just makes it easier for the patient, you can try it. And then if it's bothersome to do the competing response after a while, then you can try perhaps remove it again and see if they can do it without. So, but obviously it's very hard to say. And I have a feeling, and this is also kind of like from the ERP standpoint, if you go to in North America, especially US, I would say that they do not even think about the ERP treatment. So they start kind of in another pathway. They start by picking one tic at a time, like the most bothersome tic, and then they work with that for a few sessions, and then they move on to the next tic with just a competing response training. And then they also have another part, which is the awareness training, where they try to like becoming more aware of the tics before they start suppressing them. And in ERP, the awareness training is a little bit more just built into using the clock and suppressing tics. The more you do that, the more aware you will become anyway, and such. So there's one study that has combined this. It's an open study. It's a Danish study. There's actually a manual out. I'm not sure it's in English. It might only be in Danish. I will talk more about that study a little bit in the next presentation. Is there any more questions here, or is it more about?
Yeah,
Tracy Hammer.
Yeah.
Tracy, thank you so much. My question is about the impact of comorbidities on ERP. Do you have any suggestion for incorporating ERP when someone has more severe ADHD? Yeah, what I did not discuss today, which because of time, which I have perhaps in my bigger master presentation, is that before choosing your treatment, you should also, of course, think about which of all these comorbidities should you start with treating. And as you may, which what I also will talk a little bit more about next time, is how effective, I mean, what should you actually tell the patient to expect? How much improvement can you really expect from behavioral therapy, from Tourette's, etc.? And in a way, there's a lot of other treatments that might be more effective, and also conditions that are more impairing for the patients than the Tourette's itself. OCD could definitely be one of these. The behavioral treatment for OCD is very effective, more effective than the ones for Tourette's, and it's also for many patients more impairing in a way, because they have avoidance behaviors. It takes more time each day, etc. And it's just another type of impairment than I mean, you can be very impaired by Tourette's as well, especially the more severe end of the cases. But many patients, or the younger kids, they're irritated by it, but perhaps not as impaired as you might be by perhaps OCD or a very severe, more severe and anxiety disorder. And then also many clinical guidelines recommend ADHD management before actually starting any behavioral therapy for Tourette's. So like if you're interested in ADHD medication, it could be a wise thing to try it out before. And there's also some medications like the alpha agonists that could potentially help a little bit with both the ADHD and the Tourette's. I'm not really sure what your local guidelines are suggesting, which medications to start with, but there are some variations you could try potentially. But I think it's always good to sit down with the family and prioritize which of all these conditions is most important to start with, because it might be very hard for the patient, especially a younger patient, or also an older patient, to actually focus on various treatment paths and conditions at the same time. And I think that's a clinical impression I probably share with many other clinicians.
I'm wondering your impression as a clinician in terms of what's easier for the patient and the therapist. Is it ERP or is it HRT? Like I'm curious, like you have a younger child or someone who's, you're worried about their ability to engage in therapy. Like what's simpler?
It's a very good question. I'm probably biased there because my origin is, I come from an OCD clinic originally, and we work a lot with ERP. Now I said actually that it's not really the same treatment, but And in our clinic also, we've had these Dutch people coming over and training us, etc. So we're kind of biased in a way. And when we look at, if you look at the paper, the paper I pasted in the chat, our naturalistic study, you can also see that in that I think it were 44 participants that had received ERP and 14 that had only 14 that had received HRT. And it's not that we force all families to pick one or the other. Rather, it's a decision for the family. We present, look, here's this, works like this, and then you can also choose this, works like this. But of course, I mean, they can probably hear from the therapist if the therapist is more interested or confident in one or the other, that many end up choosing ERP. But I think that might not be the full truth. I think also many families, when presented with the alternatives, especially with younger kids, they appreciate the ERP because we talk about, then we can use a clock and we can have like a high score list. We can make it a little bit more fun, perhaps. And perhaps it's the way we present it, but many families actually pick that because they think it sounds easy. It's a very easy rationale, easy to get started with. And also perhaps it could be made a little bit more fun with a little more like a competitive side to it. But I think if you're creative as a therapist, you can make any treatment fun as well. It's more like in the how to make it playful with the younger patients.
Thank you.